Welcome to episode 14. This is the pre-Christmas special. And look at you guys, all so dedicated. And you know what? I thought about taking a week off, but I hear a lot of you guys are working this week and a lot of you guys are working Christmas and New Year's. So you know what? I decided to do a session as well to feel your pain. But I am taking Christmas and Boxing Day off. All right. Now, we are going to go through the question regarding venous admixture. And as always, we're going to review the exams report. I'm going to let you know where to get the answers from. And we're going to present some of the key concepts. I'm going to have time for any questions that you guys have. And then I'll show you what I think a good answer structure is. And we're all going to write the answer to time. Now, this is the question that concerns venous admixture. So it's from Fed March 2007, question 9. As a short answer question, it hasn't been asked for some time, but certainly it is a favorite to ask for the Viva. But in saying that, I could potentially see it being sort of rehashed in the next sort of couple of years, because it is a really, really good question with a lot of concepts to discuss. So the question is, define venous admixture. Briefly explain how venous admixture influences arterial oxygen tension and how an increase in inspired oxygen concentration may affect this. So this is the examiner's report, and the green highlighted letters are what I think that we should focus on, and the red ones are ones that we should avoid. So the main points expected for a pass included a definition, and also we needed to talk about the sources of venous admixture with a brief description of each, an appreciation that venous admixture is a concept which may be expressed by the Shunt equation. And that, I want you guys to sort of focus on that, because a lot of times when sort of the question gets asked in terms of what are the causes of hypoxemia, venous admixture is often a concept that's often given as an answer. And what you guys need to know is that venous admixture it's a theoretical concept, okay? Shunted and VQ mismatch are the pathologies, but venous admixture is a theoretical concept. So it's a theoretical shunt, all right? And then after that, the examiner wanted a statement of effect on arterial oxygen from venous admixture with reference to the oxyhemoglobin dissociation curve, demonstrating relation of oxygen tension to hemoglobin saturation and the effect of increase inspired oxygen concentration on venous admixture. So this would be what you would have to get a good pass, and then where you would score sort of a 4 or a 5 would be these additional statements or these additional concepts. So additional marks were allocated for more detail with respect to sources of venous admixture. For example, relative contribution and magnitude of effect, the demonstration that small and large amounts of venous admixture affects the partial pressure of oxygen differently, and the explanation of the relative effect of high versus low VQ units with reference to the IsoShunt diagram and quantifying effect of increase inspired oxygen. So there's actually a lot to unpack there. And it will be a challenge to actually get all these concepts down in the 10 minutes, okay? Now, mistakes commonly made included imprecise or interchangeable use of terms. For example, oxygen content for partial pressure of oxygen, and shunt or mixed venous blood for venous admixture. And very, very common that this occurs. So just be aware that using the wrong or the incorrect terminology really changes a lot of the concepts that you're trying to describe. Okay, so just be aware that, when you are writing your answers, you are aware that every one of these, oxygen content, partial pressure of oxygen, shunt, and venous admixture are all different. And the use of the oxyhemoglobin dissociation curve to justify arguments regarding the effect of increased arterial oxygen on oxygen content. Okay. Credit was not given for vague, non-directional statements of effect or for discussion of carbon dioxide or factors which affect mixed venous PO2. So this would be a summary of the exam's report. So to gain a pass, you would have to have a definition of venous admixture with the shunt equation, and then also describe the sources of venous admixture and describe the effect of venous admixture on the partial pressure of oxygen with reference to the hemoglobin oxygen dissociation curve. To gain a good pass, when you describe the sources of venous admixture, you'd also have to describe the relative contribution and the magnitude of effect. You would have to draw the IsoShunt diagram and also a discussion of high versus low VQ units. Now, these are the chapters which I think are most important in answering this question. Chapter 7 is really the core chapter. So chapter 7 from Nunn and Lum's distribution of pulmonary ventilation and perfusion, and I've attached that as well in the post I made this afternoon. Now, chapter 10 oxygen also has some couple of paragraphs on venous admixture and the factors that would affect the arterial versus alveolar partial pressure of oxygen difference. It is quite complex, and as I said in the post, it's probably beyond anything that I've ever seen in an SAQ or asked in the Viva. And the reason for that is that it gets quite technical, and the discussions can actually take a lot longer than 10 or even like 5 minutes in the Viva. Okay. Now, I am happy to answer any questions regard to that or go through it, but it will take a bit of time just because of the complexity of the concepts that are involved there. Now, West chapter 5 has a little bit on it, but mainly you're going to find the core sort of concepts described in chapter 7 in Nunn and Lum's. All right. This is the core formula that you need to know. And by knowing this formula, you can actually create your definition from that. Okay, so I'm going to show you how. Now, first of all, the challenge is to try to memorize this formula. And the way to do it is to have a think about the individual components here. So we've got the shunt fraction, we've got the total blood flow, we've got the content, oxygen content in end capillary blood, oxygen content in arterial blood, and oxygen content in mixed venous blood. And the way to sort of think about this is that theoretically, the blood which has the highest content is going to be end capillary, because the end capillary is where it is going to be matched up with the alveolar gas. So in terms of partial pressure of oxygen, that's going to be the highest. All right. So if you think in terms of oxygen content, CCO2 will always be more than the arterial content, which will be more than the mixed venous content. Okay. And when you know this rule here, what you'll know is that the bigger number will always go on the left-hand side. So the bigger number is always on the left-hand side. Okay. And then after that, you can put arterial oxygen on top and then mixed venous oxygen content at the bottom. Now, after you're able to write this formula down, if you get asked, or in the Viva or in the SAQs, you want to explain this in words, it is as simple as this. It is, and I use a green pen. It is the amount of mixed venous blood that needs to be added to end capillary blood to see the observed difference between arterial and end capillary PO2. All right. So I'll just say that again. And I use a blue pen. It is the amount of mixed venous blood that needs to be added to end capillary blood to see the observed difference between arterial and end capillary PO2. And this is the big the difference here, is that we're talking about content, but the definition actually looks at the difference in the partial pressure of oxygen. All right. So we're looking at the difference in PO2 between the arterial side, between the arterial side versus the end capillary side. Now you're going to ask me, why are we looking at partial pressure of oxygen instead of content? That is a very, very good question. Now, they are related. So with regards to the hemoglobin oxygen dissociation curve, where you've got partial pressure on your x-axis, you can also draw that with content on the y-axis. All right. So normally you have saturations on the y-axis, but you can have content as well on the y-axis. And that's where the relation is between partial pressure and content. And I think that the reason why they use partial pressure is because of the other factors that affect content. So things like hemoglobin, things like your CO2, your pH, anything that affects your hemoglobin oxygen dissociation curve. So we'll shift it left or right. So temperature, 2,3 dpg, and CO2 as well. And that's where this is all sort of discussed in its complexity in chapter 10. As I said, you probably don't need to go into that much detail, but know that when we think about venous admixture and the way that we describe the shunt equation, it's looking at the difference in the partial pressure of oxygen. All right. Now, next slide here. All right. So I want you guys to practice it with me. So get a blank sheet of paper out. And I think a lot of you guys may have already been able to sort of write this quite proficiently, but let's do it again together. Okay. So we have QS over your total blood flow equals, and remember, you want the biggest amount of content on the left-hand side. So end capillary content of oxygen on the left-hand side minus your arterial content, and then minus at the bottom, your mixed venous content. All right. And then we're going to practice in your head, sort of practice the definition. So the definition is, it's the amount of mixed venous blood that needs to be added to end capillary blood to see the observed difference between arterial and end capillary PO2. So that's it here. So venous admixture is the calculated amount of mixed venous blood that is added to pulmonary and capillary blood to produce the observed difference between arterial and pulmonary and capillary PO2. And it's a derivation of the conservation of mass. So what I mean by that is that the cardiac output multiplied by the arterial oxygen content will equal the end capillary blood multiplied by the end capillary oxygen content plus the shunt, the amount of shunt you have, multiplied by the mixed venous oxygen content. And let me just show you that on this slide here and what that sort of means. So what we're saying is that this bit here, okay, the amount of oxygen that's in here, all right, is what's called your arterial oxygen content. And that's a function of both your total cardiac output multiplied by your arterial content. And to get this, it is a sum of what's happening here, which is your end capillary oxygen content, and what's happening here, which is your mixed venous oxygen content. And this represents your shunt, okay? And this represents your pulmonary and capillary blood. Okay. So that's how the formula is derived. Again, you don't need to derive the formula, but I think it is important to understand where the mathematics of it comes from. Okay, and hopefully the diagram is also able to sort of show you that diagrammatically as well. Now, with a venous admixture, so it's a combination of both shunt and VQ mismatch. All right, and this is where we go into that discussion about what causes each. So venous admixture is a theoretical shunt because it includes both true shunt and VQ mismatch. So what's true shunt? True shunt is blood that passes from the right to left side of the heart without participating in gas exchange. And true shunt has a VQ ratio of 0. So true shunt has no ventilation, but perfusion. Okay, so that's where the VQ is 0. Now, the causes of true shunt are both physiological and pathological. And this is all from nuns, so the numbers. So physiological shunt consists of the Thebesian veins, which is from the heart, and that represents 0.3% of your cardiac output, and your bronchial veins, which represents less than 1% of your cardiac output. Now, in pathological states, such as emphysema and bronchiectasis, that can increase up to 10%, all right? Now, pathological causes of shunts, so they include congenital heart disease, specifically right to left. And the most common causes would be anything that causes right ventricular outflow tract obstruction. So all the congenital heart diseases like pulmonary atresia, pulmonary valve stenosis, hypoplastic right heart, tetralogy of Fallot, and then Eisenmenger syndrome. So that's when you got prolonged left to right shunt. And what happens is that with the increase in blood flow, causes pulmonary hypertension and then leads to that reversal of shunt. So you've gone from left to right now to right to left, okay? And congenital heart disease is probably the most significant cause of shunt, and that will be present in the pediatric population. And yeah, and that's where you will see a lot of low saturations with those patients. Now, other pathological causes include pneumonia and atelectasis, and that's relevant for a lot of the adult population that we see. Now, what is the effect of shunt on the partial pressure of arterial oxygen? So because the partial pressure of oxygen is normally on the flat part of the hemoglobin oxygen dissociation curve, small changes in content from venous admixture results in large changes in the partial pressure of oxygen. And I'll show you that in the next slide with the curve. But you've got this table here, and you see that this is the effect of 5% of shunt, or they've got venous admixture. So that's theoretical shunt. And what happens is that you get the oxygen content going from 19.9 to 19.6. So that you can see for the content, it's a very small change of 0.3 mils per deciliter. But have a look at the effect of the partial pressure. So you've gone from 105 to 90. Okay. So you see that's a difference of 15 millimeters of mercury. So that's over a 10% change. Now, that is due to the hemoglobin oxygen dissociation curve and where it functions on the flat part. All right, and you'll see that the effect diminishes at the lower partial pressures of oxygen, because that's when the dissociation curve is steeper and you lose that effect. So this is the graph this is the diagram from West. And what this shows is the depression of arterial PO2 by shunt during 100% of oxygen breathing. So you've got your PO2 up to, and the maximum you can have with a FiO2 of 1 theoretically is 663. Okay. And again, you see that, so you've got a FiO2 of 1 and you've got your amount of oxygen concentration should be about 22 would be the maximum it can have. And with shunt, what it does is it decreases it by this small amount here. Okay. So you've gone from here, and because it dilutes it, you're going from here to this point. So this is your oxygen content. All right. So your oxygen content is being diluted by shunt. Now, with the oxygen content, you've gone from here to here, but have a look what happens on your partial pressure on the x-axis. You've gone from here, this spot here, all the way to here. All right. So you've gone from here to here. And that is a massive change. So you're looking at, you've got a change of over 400 millimeters of mercury. So over 400 millimeters of mercury. So this is on an FiO2 of 1. And this is the effect that shunt has on the partial pressure of oxygen. So this is quite an extreme example. The previous example, which was in nuns, so this table here, this was on someone on a FiO2 of 0.21, okay, on sort of room air. And this is the effect of shunt on someone who's on breathing on an FiO2 of 100%. Right. Now, this wasn't asked on the question, but I think it's worth sort of going through it. What's the effect of shunt on the partial pressure of CO2? So because the CO2 dissociation curve is steep, small changes in CO2 content from venous admixture results in small changes in the partial pressure of CO2. And I'll show you that on the next graph. And also the other thing is that clinically, when venous admixture actually lowers the partial pressure of CO2 because with the decrease in the partial pressure of oxygen, that activates your carotid bodies, your peripheral chemoreceptors, which then increases your minute ventilation, which then drives down your CO2. All right. So in the spontaneously breathing patient, venous admixture or shunt and VQ mismatch does not increase your CO2. All right. Now, this is for someone who has a fixed ventilation. And what happens again is that we've got a venous admixture here, and you can see that the CO2 content has gone from 49.7 to 50. But have a look at the partial pressure of CO2. It's gone from 39.7 to 40. So the change is 0.3 mils per deciliter here. And you look at the pressure change, it's only 0.3 millimeters of mercury. And the reason for that is because of the shape of the CO2 dissociation curve. All right. So what that text is saying is that hypothetically, let's say you function on this point here, small changes in content. All right. So from here to here, because of the steepness of the curve, it will, we actually go up because that's where the millimeters of mercury is. It will only cause a small change in your CO2, all right, just because of how steep that curve is compared to the hemoglobin oxygen dissociation curve, where you're on the flat part of the curve, where small changes leads to big changes in the partial pressure. And as I said on this paragraph here, the effect diminishes at lower partial pressures of oxygen when the dissociation curve is steeper. So what that means is that if, let's say you're functioning on this steep part of the curve, then any sort of effect of shunt will have a much lower effect on the partial pressure of oxygen. All right. And that is a very important concept, because we're going to build on that concept when we talk about high versus low VQ units. Now you hear the term VQ mismatch and VQ scatter. And I'll tell you what they mean. I think there's a lot of confusion between them both, and a lot of times people use it interchangeably. VQ mismatch is essentially all the VQ numbers between 0 and infinity, but not including 1, and also not including 0 and not including infinity. All right. Because when you've got a VQ of 0, that's shunt. When you've got a VQ of infinity, that is alveolar dead space. And when you've got a VQ of 1, that's ideal alveolar matching. Now, the thing to note is that VQ mismatch does not just include VQ ratios less than 1. All right. I think there are some internet sources out there which talk about VQ ratios less than 1. I think that is probably more clinically relevant, but when textbooks talk about VQ ratios, it's not just less than 1. It can also be more than 1 also, which means that it's trending towards alveolar dead space. Now you hear the term VQ scatter being used. So VQ scatter represents the spread of VQ ratios. In other words, when you've got increase in VQ scatter, it means you have an increase in the spread of VQ ratios. And when you're talking about the spread of VQ ratios, you can have low VQ units, mid VQ units, and high VQ units. So low VQ units are trending towards shunt. Mid VQ units are centered around the ideal, so a VQ ratio of around 1, and high VQ units are trending towards dead space. All right. So remember, VQ mismatch just talks about, an individual VQ ratio. So VQ ratio between 0 and infinity, but not including 1. And VQ scatter describes the spread of VQ ratios. In other words, you are increasing the amount of low, mid, and high VQ units. All right. Now, when you've got increase in VQ scatter, you do get an increase in your alveolar arterial gradient. In other words, you do get a reduction in the partial pressure of arterial oxygen. And the reason for that is that your arterial PO2 will be dominated by low VQ units, because by its definition, low VQ units have more perfusion. All right. And I'll explain that to you in the next slide. And then the other thing also is that due to the hemoglobin oxygen dissociation curve, so due to its shape, low VQ units will have greater effect on arterial oxygen content than high VQ units. And again, I think I'll explain that to you better in this slide here. So now the first thing that we need to understand is when we look at low VQ units. So low VQ units have low ventilation, but proportionately a lot higher perfusion, okay? You compare that with high VQ units, which have high ventilation, but low perfusion. All right, so what I'll do is I'll say that Q here is high, whereas for the high VQ units, perfusion here is low. So what that means is that when you sum it all together, because the low VQ units have more perfusion, they are going to be contributing a lot more in terms of their effect to the total arterial PO2. All right. Now, the second thing I talked about was where they sit on the hemoglobin oxygen dissociation curve. So what you'll note is that with low VQ units, they have a alveolar oxygen, and this is just sort of some arbitrary numbers, let's say around 40 millimeters of mercury, whereas the high VQ units will tend to have a much higher alveolar oxygen of 120 millimeters of mercury. And this is sort of where they sit on the average. And the thing to note is that when you've got blood passing through the high VQ units, they will be well oxygenated, all right? But what you'll see is that where they sit on because they sit on the flat part of the hemoglobin oxygen dissociation curve, again, you see that the amount of content they're able to increase by is far less than the decrease in content that you get with low VQ units, because low VQ units are functioning on the steep part of the curve, all right? So in other words, they're able to push that amount of content down. And so that is why the concept is that when you've got VQ scatter, it is dominated by low VQ units, all right? So in other words, that your arterial PO2 with VQ scatter will always trend towards the low VQ units. And that's essentially what that statement sort of means. Now, this is the IsoShunt diagram, and it is something that you will need to learn to draw, and I'll show you how to actually think about it. So how to actually draw it. All right. Now, the thing to note is that each 1% of true shunt reduces the maximum partial pressure of oxygen by approximately 15 to 22 millimeters of mercury. So for every 1% of shunt that you get, despite you increasing the fraction of inspired oxygen, the amount of, the maximum PaO2 that you can achieve is reduced by 15 to 22 millimeters of mercury. The other thing to note is that you see these bands. So the reason why they're bands is that when you look at the calculation of venous admixture, it does require knowledge of the actual arterial mixed venous oxygen content difference. And when you look at the content equation, it's both a function of hemoglobin as well as a function of your alveolar gas equation, which is where CO2 comes into play, as well as a function of the hemoglobin oxygen dissociation curve, where you convert content into partial pressure of oxygen. So things that would shift the hemoglobin oxygen dissociation curve would be CO2. And in fact, in some of the other experiments, you'll also see them quote what the pH is as well, and the temperature as well. Okay, but essentially the bands on the left-hand side represent the higher hemoglobin and the lower PaCO2, and then the bands on the right-hand side here represent a lower hemoglobin and a higher partial pressure of CO2. Now, you don't need to draw bands in. I don't think you need to draw bands in for this diagram here. And the only time I think you may need to explain this is if you got shown this diagram. But otherwise, I think that drawing lines are fine. Now, this is the way to have a think about drawing this diagram. So on the x-axis, you've got your fraction inspired of oxygen here. Okay. So that's on your x-axis. On your y-axis, you've got arterial PO2. Now, remember what I said, that the maximum arterial PO2 is going to be about 660. Okay, but you can put 600 just for sort of ease of remembering. So 0 to 100. And when you've got 0% shunt, all right, when you're breathing on FiO2 of 0.21, you're going to sit at about 100 millimeters of mercury. Okay, and all you need to do for a 0% shunt is draw it all the way up to a straight line up to 600. Now, when you've got 50% shunt, that's the other bad one. That's just a straight line across. So the next one to draw is 50% shunt. So with 50% shunt, all right, it's literally just a straight. So go halfway at about sort of, 15 millimeters of mercury, and pretty much just draw it straight across there. Now, the next one you want to draw is going to be your 30% shunt. So at about, and this is the number that you'll often get quoted, at about 30% shunt, this is where increasing FiO2 won't have an effect in terms of improving the arterial PO2. All right, so you know that the one you can draw after that would be 30. So just draw it a little bit up. And what you want to do is you want to reach it to 100 millimeters of mercury. Okay. And then this is, so this is the cool bit here. All right. So the next one you want to draw is in between 30. So between 0 and 30 is 15%. All right. And the thing to remember is that 15%, which is between 0 to 30, is in between the maximum amount of PO2 you can have, which is 660 and 100. So if you add them up together, it's 760, and you divide it by 2, it's around sort of 380, 400. All right, which is where this number is. So for 15%, that's where it's going to end up. It's going to end up halfway. All right. And then pretty much you can just add the other ones in. But those are probably the 4 main ones you want to draw. All right. So I'll just sort of summarize it here. So you've got your fraction inspired of oxygen, which goes from 0.21 to 1. You've got your partial pressure of oxygen, which goes from 0 to 660. All right. So at about 0.21, you go from 100, this 0% shunt. You have that straight up. Okay, so that's 0% shunt. 50% shunt is literally a straight line. 30% shunt, oh, sorry, apologies. What I should have done is 0%. 50% shunt is just a straight line, which goes down halfway. So this is 50% shunt. 30% shunt needs to end up at 100 millimeters of mercury. So you go from here to here, and that's 30% shunt. And then 15% shunt, remember, ends up halfway, and that is sort of at 400. Okay. 15% shunt. And that's pretty much how you draw this IsoShunt diagram. All right, we're going to practice this. So get a piece of paper, and we're going to draw it together. All right, just using those rules. So we're going to practice it. So draw your y-axis, draw your x-axis, have your fraction inspired oxygen here between 0.21 and 1. You have your PaO2 here between 0 and 660. Okay, and then after that, the important one to have here is 100 millimeters of mercury, and you can go 200, 300, 400, 500, 660. Okay, so remember that if you have 0% shunt, you're going to go from 100 to 660, and it's just pretty much a straight line. Okay, so that's 0% shunt. With 50% shunt, you're going to go halfway, and it's just a straight line across. So that's 50% shunt. The next one to know is your 30% shunt. So it's going to come up here, and it's going to slope up like this, and that's 30% shunt. And then the last one to draw is your 15% shunt. So that's going to sit up here. So you're going to go from here to here. Okay, and that's a 15% shunt. And then after that, it's up to you. You can add the other ones in if you want. You can add the 10, 5s, and 20 and 25%. But those would be the main ones that you draw. Now, this is the effect of FiO2 on VQ mismatch. And what this diagram is showing is that increasing FiO2 from a fraction inspired of 0.21, all right, so VQ mismatch with no shunt will improve the partial pressure of oxygen beyond the initial IsoShunt band. And what that means is, let's say you've got a VQ mismatch of, which is quite severe, which is what we call grade 4. So if you look at that, if you look at grade 4, that sort of sits on the 30% shunt, shunt line or IsoShunt band. But with true VQ mismatch, so no shunt, what you'll find is that you're able to actually improve your partial pressure of oxygen. So it moves, you can see it moves beyond the initial IsoShunt band. Now, I guess what's really interesting is what's happening up here. Okay. And so, you know, what this diagram suggests is that as you increase your oxygen concentration, despite having a very sort of severe VQ mismatch, what this diagram is suggesting is that you can actually correct your arterial PO2 back to normal. Now, I have never seen this clinically, and I don't think this is something that you could reproduce clinically with someone with such severe VQ mismatch. And so what I did was I did have a look at the original study, and this is just more for you just to, I guess, appreciate that the way that those VQ mismatches were plotted was from a computer model. All right. So in other words, the PaO2 versus FiO2 predicted from a multi-compartment model of ventilation, perfusion, maldistribution, in which the ratio is increased progressively, and it's essentially a computer program. All right. And you can see here that the computer program stops off at an FiO2 of 0.6, whereas this one here, it's sort of transposing it to 100%, and that's why, you know, if they continue the gradient, it goes up to almost normal. But that's not quite true. Okay, so just be aware of that, because I think that sometimes I think having diagrams like this, I think, can be a little bit confusing, because we immediately think, oh, geez, you know, someone with VQ mismatch, if I give them 100% oxygen, they should have a PO2 of above 600. But, you know, I've never seen that clinically. And, you know, this makes sense to me that this was just done as a computer model, and it was done to a FiO2 of 0.6, not to a FiO2 of 1. Okay, so this would be the structure on how I would answer this question. So with the question, define venous admixture, briefly explain how venous admixture influences arterial oxygen tension and how an increase in inspired oxygen concentration may affect this. There's really three parts to this question. There's you need to define venous admixture. And then after that, you need to explain how venous admixture influences arterial oxygen tension. And then the third one is how an increase in inspired oxygen concentration may affect this. So the first bit about the definition of venous admixture will include the formula. It's also going to have a description of the sources, so both shunt and VQ mismatch. And if you have time to quantify it. And then after that, we're going to describe the effect of shunt on not just content, but on the partial pressure of oxygen, and as well as the effect of VQ scatter on content, as well as the partial pressure of oxygen. And I think the last one would just be a quick diagram with the IsoShunt diagram, which will be able to explain how an increase in inspired oxygen concentration may affect this, along with the effect of the different degrees of shunt. All right, guys. Okay, hold on. This one's a diagram drawing question. So I've got my ruler, and I've got my pen. 1, 2, black and blue pen. Actually, you can have a red pen as well, but I think two color pens are good. All right. Okay, so in my head already, I know that there's 3 sections to this. So I'm going to try to separate it into 3 pages. Okay. All right. Ready? And let's go. All right. So I'm going to have my definition. Second page. I'm going to talk about the effect of arterial on arterial oxygen tension. Last page, I'll have the effect of FiO2. I'm going to start off with my shunt equation. CO2 minus the two, and then venous admixture is the calculated mixed venous blood that is added to pulmonary and capillary blood to produce the observed difference between arterial and capillary PO2. Contribution to venous admixture is shunt or true shunt, where the VQ equals 0 and 2 VQ mismatch. So true shunt can be divided into physiological and pathological, and physiological would be the Bayesian veins, which represents 0.3% of cardiac output, and also the bronchial veins, which is less than 1% of cardiac output. Congenital would be, pathological would be congenital right to left shunts, and also pneumonia and atelectasis. And VQ mismatch would be pathological, and common ones would be emphysema, asthma. Okay, so what's the effect of arterial oxygen tension? So in other words, small changes in content from shunt results in large changes in PaO2, because PaO2 normally is on the flat part of the HbO2 curve. To content so just need to exaggerate this a little bit more. Okay, so O2 content, all right. And then we're going to talk about VQ scatter. So decrease content, decrease from shunt. Okay, so increase VQ scatter, decrease PaO2 because of low VQ units, which have A, more perfusion, and B, greater decrease in oxygen content compared to the increase in oxygen content with high VQ units due to where they lie on the HbO2 dissociation curve. Okay, so draw this curve here. Deciliter, okay, oxygen. I think this one here is oxygen, oxygen content again. Let's put deciliter, and then we're going to have PO2, millimeters of mercury. And again, we're going to draw that hemoglobin oxygen dissociation curve. And we're going to say that this is where low VQ units this is high VQ units. So therefore they've got more perfusion and less O2 content compared to high VQ units. So low VQ units have more perfusion and less oxygen content. All right, the last one would be my IsoShunt diagram. So just like this one. Yeah, so we can have FiO2, we have PaO2, 0 to 660, 0.21 to 1, 100, 200, 300, 400, 500. So that's 0% shunt, 50% shunt, 30% shunt, 100, 15% shunt. And then I can say each 1% shunt reduces the max PaO2 by 15 to 22 millimeters of mercury, as shown in the IsoShunt diagram above. Okay. So I've got a minute left, and what do I need to do? Oxygen content. Let's improve my handwriting here from shunt. Fusion and less oxygen content. I guess shunt. Shunt. Passes from right to left side of the heart without participating in gas exchange. All right, there we go. That's 9. Yeah, I think that on reflection, probably I need to probably set this out a little bit better in terms of the description of this from shunt and then this from VQ mismatch. So, I mean, I've just noticed an obvious error here. I've just put increase in VQ, whereas it should be increase in VQ scatter. Okay. Right. But yeah, so that would be my answer here. Not a perfect answer, but yeah, good stuff, guys. Have a Merry Christmas, and I will see you guys hopefully next week sometime. All right. It's hard, hey? We're nearly there, 2022, and this is when we start coming up the ramp up phase. So it's okay to, you know, feel like you're still sort of struggling through at the moment. And I think that the way to look at it is that you still want to be able to feel like you're improving, you're getting better each day, because ultimately you don't want to reach your peak now. You want to be able to still keep yourself motivated, still feel like you know, you've got room for improvement, because if you reach your peak now, you've got nowhere else to go from here. Okay, you want to be reaching your peak at the end of Feb. All right, so still got sort of 8 weeks, almost 10 weeks. Sorry to scare you. 10 weeks.